Hello everyone, welcome to our EXS306 group case study presentation with Cameron, Lilah, Ashton and myself, Connor. Our case study was number 2, where we were presented with the client named Miss Fairbairn, who was a 67-year-old female who experiences 7 out of 10 pain in her right shoulder after having a fall 12 months ago. She feels this pain most when performing functional activities such as hanging up the washing and dressing herself. Miss Fairbairn is a nurse who works part-time and has had an extensive sporting history of basketball and netball, which she retired from 15 years ago. She does not want to retire anytime soon from her job. Miss Fairbairn was referred to us by her physician to come join our exercise class where we specialise with individuals with musculoskeletal upper limb pain, typically having around 3 to 5 participants attend. Prior to our initial class, we were going through a subjective and objective examination consisting of observation, palpation, pain-free range of motion, active function, and physical discomfort. Miss Fairbairn will be attending the class for 2 months, where we will work towards getting her back to working normally and having pain-free movement.
In this video, we're going to go over how we developed our presentation, how we dealt with group work, a background behind our presented problem, an introduction to who Miss Fairbairn is, her goals and other considerations, the assessment approach, the subjective and objective assessment and what it entails, findings from these assessments and potential actions to consider, the 2-month management plan for Miss Fairbairn, and a review of what we've learned, followed by a reference list.
Alright, for the group work section of our PowerPoint, we, like our collaboration and communication times, were scheduled specific meetings, we delegated responsibilities and workload. We collaborated together in the 360 building, the new building obviously, and then we had a shared PowerPoint and we were messaging through Messenger and email. We were using stuff like Microsoft PowerPoint, Teams, Outlook, Messenger, and then just phones and laptops, for the daily things. Our source Outlook was PubMed, just general textbook stuff, Murdoch libraries, and Google Scholar. That was another good one we used. And then some challenges we faced while bringing this PowerPoint together was that we had a loss of a group member, dropping out of our unit, just other life commitments, getting sick, for instance, was a part of it, and then just figuring out a time and place to get together, just because we all had outside work commitments.
So Miss Fairbairn appears to have a stage 3 shoulder adhesive capsulitis, or otherwise known as frozen shoulder. Upon the referral, the physician noted this and diagnosed it during her practice with various physical tests and an arthroscopy. The physician referred Miss Fairbairn onto us to assess the extent of the injury's limitations and design a program in our class for her recovery. Her injury seemed to stem from her initial trauma to the shoulder 12 months ago, which was a 7 out of 10 pain. She couldn't move her arm correctly for weeks. The pain was at its highest in the first few months, fading into a constant dull ache, with the strength of her arm still there. Since then, the shoulder hasn't been the same. Now there is a moderate pain and difficulty when moving it, but especially in the end ranges of motion. Therefore, greater pain and discomfort comes with movement and stiffness when trying to do functional activities such as getting dressed or activities at work such as setting up IV drips and equipment that is above the head. Upon referral, we know that the injury is described as stage 3, and this is characterized by the following: a 9 to 15 month period, pain only with movement and at the end ranges of motion, compensating movements with the scapula rather than the shoulder joint, slight muscular atrophy compared to the contralateral limb, and tightening of the glenohumeral joint capsule lining. Overall, it mainly comes in the form of reduced range of motion in shoulder flexion, abduction, extension, lateral as well as medial rotation, and pain when only moving.
Miss Fairbairn is a patient who is 67 years old with a positive exercise history, but due to injuries has been unable to do activities she enjoys, such as swimming. She also suffers from type 1 diabetes. In the past, Miss Fairbairn has found immobilizing the injury has helped treat the injury, as she is afraid to keep moving it and having it become worse, and so is getting a friend to assist her with her daily tasks. With this, she is finding it hard to complete simple tasks at work and is unwilling to retire being a part-time nurse, and becoming more stressed about her injury not returning to normal function and solely relying on her good arm.
The assessment approach we have conducted begins with assessing the information from Miss Fairbairn's physician referral, followed by a subjective examination, which was in a client-styled interview to gather information on her injury, pain, past medical conditions, and etc. We then gained consent from her to conduct an objective examination which included palpation, range of motion, and muscular testing. From the subjective and objective information we gathered, we were able to separate them into a list of major versus minor problems and identify client goals towards rehabilitation. We then made a maintenance plan to address the problem areas and the client goals in our upper limb musculoskeletal class. Miss Fairbairn was referred to us by her physician, Dr. Rowe. On the referral, Dr. Rowe indicated that she has frozen shoulder syndrome following a fall and her susceptibility from diabetes. Dr. Rowe referred her to us for our exercise class we hold at Murdoch University Exercise Physiology for those who have upper limb musculoskeletal pain, as it will help reduce the stiffness and pain and increase the range of motion in her shoulder. The subjective examination was taken in a client-based interview, aiming to gather as much background information on the presented issue, competing factors, medical history, social and work factors. By completing a subjective examination, efficient and effective objective examination can be planned and tailored. The subjective examination can identify symptoms and the relationship of these, where pain is felt and its easing and worsening factors, how the patient feels about the condition and rehabilitation and their expectations from the treatment, such as whether they're anxious or their goal is to have pain-free range of motion, the patient's medical history, history of the presented issue, and family medical history, and also medications the patient is taking, which can allow us to understand if the issue presented may be due to underlying factors or conditions contributing. The subjective examination identified that Miss Fairbairn has pain in her right shoulder following a fall 12 months ago, and it is a 7 out of 10 when she is sedentary, but worsens when performing functional tasks such as dressing herself or work-related tasks such as lifting patients to and from bed. Since the injury, she has noticed her shoulder to feel stiff and a dull ache running down her arm. The pain is static when she is sedentary, but has noticed that it worsens when moving the joint, particularly whilst at work. Her main goal is to be pain-free while she works her part-time job as a nurse. The pain eases when she is resting and taking NSAIDs. She has diabetes and her father also had the condition. She enjoys being active and is an ex-netball and basketball player and also enjoys swimming. She has a partner named Doug and who lives with her and helps her. Observation measures were taken as soon as Miss Fairbairn walked into our clinic and sat down on the chair. We then observed her resting posture as well as completing some static movements with her, including putting her hands on her hips. We then observed her muscle size and differences in her trapezius, rhomboids and rotator cuff muscles and her scapula, along with her clavicular head, humeral head positioning and scapulohumeral rhythm when moving the shoulder about. This allowed us to assess the position, symmetry and movement of her shoulders and identify any abnormalities. We then completed 4-point palpation on her shoulder, palpating the anterior, posterior, superior and lateral portions of the shoulder. From palpation, we were able to identify areas that were tender, weak, had pain, were swollen, inflamed, along with any other abnormalities and muscular atrophy. For range of motion, we tested Miss Fairbairn's shoulder's active range of motion, which is when motion is produced by an active contraction of a muscle. We tested this using a goniometer, comparing a result to normative data, along with her left shoulder, which is considered an unaffected limb, to determine her normal functional range. Throughout the assessment, we had Mrs. Fairbairn sat in an upright position on a chair. The measures we took were flexion, extension, abduction, adduction, medial rotation, and lateral rotation. The Oxford Scale is a clinical assessment tool that can be used to evaluate the functional status, muscular strength, and severity of shoulder issues. When testing, the client is required to perform specific movements against gravity and resistance to be graded based on their muscular strength. We used this scale on Miss Fairbairn's deltoid muscle, rotator cuff muscles, and scapular stabilizers, which are responsible for movements including flexion, extension, abduction, adduction, medial, and lateral rotation. The Oxford Scale is scored from 0 to 5, with 0 being no detectable muscle contraction and 5 being normative strength.
Miss Fairbairn has decreased range of motion in her right shoulder, as shown by our findings above, and was found to be well below average in her right shoulder and rotator cuff area. The picture beside is how Miss Fairbairn's posture is currently sitting, and it is clear to see why she is struggling to do basic tasks. Her muscles have tightened up and are afraid to move and contract due to pain and fear of worsening her injury. Our goal is to complete simple stretching exercises so we can loosen the frozen shoulder and begin to build confidence in the area.
As found on the previous slide, the major issues found were the lack of range of motion about the shoulder joint, more specifically in the flexion, extension, abduction, and lateral rotation of the shoulder. Following on from this, due to the immobilization and disuse of the arm resulting in atrophy of the shoulder, this also has to be strengthened and also in those movements. These issues are what we will be mainly addressing in the management plan, as improving them will get her back to having ability to doing her daily tasks, performing at work, and reducing her pain. A minor issue that we found would be correcting the scapular tilting, which occurred from compensating the shoulder movements with scapular movements, and this is a result of the restricted range of motion at the shoulder. This is a minor issue, as correcting the scapular positioning will not address her pain or the restricted range of motion at the glenohumeral joint, as it resulted from compensation rather than lack of range of motion or strength. This still needs to be addressed, as there is obvious imbalance between the upper trapezius and lower trapezius muscles, as well as the serratus anterior.
During weeks 1 and 2 of Mrs. Fairbairn's rehab program, our primary objective is to establish a baseline and effectively manage her pain levels. In week 1, we conduct a thorough analysis of Mrs. Fairbairn's pain levels, functional limitations, range of motion, and strength to gain a comprehensive understanding of her condition. Additionally, we will introduce pain management strategies such as the use of cold or hot therapy and educate Ms. Fairbairn on proper posture and ergonomic techniques to alleviate discomfort during daily activities. As part of early mobility exercises, Ms. Fairbairn may engage in finger walks and cross-body reaches with holds to gently mobilize the shoulder joint and surrounding tissues. Furthermore, we integrate foam rolling into a routine to alleviate muscle tension and discomfort. As we progress into week 2, Ms. Fairbairn continues with mobility exercises, including shoulder wands and finger walks, to further improve range of motion and reduce stiffness. Additionally, she learns how to manage pain therapy through techniques such as cold or hot therapy. Throughout these initial weeks, our team maintains close monitoring and communication with Ms. Fairbairn to ensure her comfort and progress, laying a solid foundation for the subsequent phases of her rehab journey. Moving into weeks 3 and 4, our focus transitions towards incorporating strengthening, stability, and passive range of motion exercises to further Ms. Fairbairn's progress. In week 3, Ms. Fairbairn begins with outward and inward rotations, wall slides, chest stretches in a doorway, which are aimed at enhancing shoulder mobility and initiating muscle activation. These exercises are performed with caution, emphasizing controlled movements to prevent exacerbating any existing discomfort. Additionally, stability exercises such as wall push-offs can be introduced to enhance shoulder stability and control. By week 4, Ms. Fairbairn progresses to flexion against the wall, extension against the wall, and abduction against the wall, each being held for 30 seconds to further challenge shoulder mobility and stability. These exercises are accompanied by resistance band rows, which target the upper back muscles in aid of improving posture and shoulder function. Ms. Fairbairn also incorporates passive range of motion exercises such as a pendulum stretch aimed at maintaining or improving shoulder flexibility. As we move forward into week 5 and 6, the rehab program transitions towards functional integration and neuromuscular training. Ms. Fairbairn engages in exercises such as resistance band rows, which focus on mimicking lifting actions and improving overall shoulder strength and stability. Additionally, seated 1 kilo dumbbell presses and 1 kilo side lateral raises are introduced to simulate daily activities involving reaching and lifting. These exercises are accompanied by stability exercises such as wall push-offs, aiming at enhancing shoulder stability and control in functional movements. In weeks 7 and 8, the focus shifts towards progression and maintenance. Ms. Fairbairn progresses to 1 kilo dumbbell push presses and towel stretches, challenging shoulder strength and flexibility. Additionally, exercises such as band front raises and band lateral raises are incorporated to further enhance shoulder strength and stability. Throughout these weeks, Ms. Fairbairn also engaged in exercises like farmer walks, shoulder shrugs, aimed at improving overall shoulder function and promoting long-term maintenance of gains achieved during the rehab program. Continuous monitoring and re-evaluation will be necessary to track progress, modify the exercise program as necessary, and handle any new problems or concerns over the 2 months management phase. For the rehab plan to be successful, Ms. Fairbairn must have an open line of communication to us as exercise scientists and other healthcare professionals.
So on this slide here, you can see our program that we've made over the 8 weeks or 2 months that we're going to be using to help Ms. Fairbairn with her shoulder. We've started with some slow stretches just to get that arm moving, and we've slowly increased the intensity and duration, and also added some weights around week 7. We've tried to make these able for her to complete in her group classes, because she has mentioned that she'd prefer to do some group classes rather than one-on-one stuff. But through this, you can see that we've gone from something like foam rolling, finger walks, up to something like a 1 kilo dumbbell push press, single arm dumbbell press, and then at the end just finished with 30 seconds of different stretches just to finalize her program. These could also be put into any other exercise programs that she's working with. If she does some classes, she could just add them in herself, or we'd have a class ran with all the exercises being utilized.
Our key takeaway that we learned from this project is how important communication is in group work, as without it we would not have been able to organise times to meet, delegate responsibilities, or create a cohesive presentation. We also discovered that one of our fellow students was unenrolling in the unit, therefore causing us to have to pick up topics and communicate with one another to ensure it was all catered for. Another major learning we had was navigating everybody's individual life and commitments, meaning we had to adapt our schedules in order to collaborate. In relation to the topic itself, we discovered there is multiple pathways that could be prescribed to treat our client, and depending who you ask, each person can hold different views and ideas of what is the best course of action to take care for our client. Since our client was accustomed to exercise and sport, it made it easier to administer a management plan, but we realized this would look different for somebody who may not enjoy physical activity.